So the chairperson for the next meeting is Dr. Malay Sharma, Dr. Praveer Rai, Dr. Sameer Mohindra, and Dr. Nitin Gupta. Are they all of them has joined?
Yeah, here.
Yeah. Hi, Sandeep.
Hi,
Sameer. Hi,
Hi,
Sameer.
Rajesh. Good morning to everyone.
Good morning. Malay is there?
Yes.
So I think the next session, just before starting, Dr. Moon, Dr. Sood, Dr. Pramod Garg, Dr. Kida, and Dr. Sandeep Laktakia. And there's one more addition, Dr. Mohan Ramchandani, because I have changed a little bit of schedule so we can continue the panel discussion a little bit longer. Rather than 40 minutes, we can continue for 1 hour. So the Mohan will going to speak after Sandeep Laktakia. He has a lecture after 1 hour, but I preponed so we can increase the length of panel discussion. So I hand over the mic to chairperson to start the proceeding. Thank you.
So I would like to welcome all, and I would like straight away that the first lecture should start, and I will request Dr. Moon to start with his lecture, and everybody knows Dr. Moon.
And just wanted to request everyone to stuck to the time, that is 13 minutes maximum for the lecture, 3 to 4 minutes for the discussion. So we have a fruitful discussion. That is a request to all the speakers, please.
Okay, can you hear me?
Yeah.
How about my slide is okay?
Yeah, Jong, it's perfectly all right.
Okay, thank you, Mr. Chairperson, Dr. Sharma. It's my great honor to joining this meeting, especially thanks to Vinay and Dr. Puri to having me this kind of very fantastic meeting. So I think Vinay is the real teacher for interventional EUS, not only Asia, in the world. And we are learning a lot of things from Vinay. And also Dr. Puri is very, very amazing and the sonographer, like having big lion heart. And Dr. Puri invited Korea several times, so we enjoyed it so much. And everybody knows this, stenting with conventional method stent is insertion of a stent through the structural segment in same organ by percutaneous or endoscopy. But the stenting with lumen opposing method stent is insertion of a stent through the non-structural two organs to connecting two organs by our method stent on EUS. So as you can imagine, and we can raise a lot of issues to making up that kind of procedure. So we need a completely different stent design for lumen opposing. So with the lumen opposing method stent, not only for drainage, we can access for the transluminal traveling into the target organ. So it can be some evolution of metal stenting. Axios has been a fully covered metal stent designed for lumen opposing stent at first by Boston Scientific, but originally by Ken and Exluminar of United States. So it's on very delicate, very nice and specialized delivery system, and all stenting procedure can be done by operator himself, not by the assistants. And Dr. Itoi and Bimola reported the first clinical result of EUS guided drainage using Axios. And now we are having a lot of studies using Axios stent from a large scale multinational study like EU and United States and Asian countries. However, still we are having some challenging points of Axios like this. And especially with the increasing clinical experience, and Axios can make some increase in adverse event like some bleeding. So we need more development of Axios also. This is a newly fully covered method stent for lumen apposition and Specios from Daewoo Medical. It has 25 millimeter large flanges to anchoring. And the distance of two flanges is 20 millimeter, but after complete folding back of two flanges for anchoring, the distance of two flanges is just 7 millimeter. And comparing with Axios, it's on 10 French conventional delivery system, so very familiar to the operator. And Anthony compared the US specific metal stent on different types of anastomosis, and Spacious and Axios had their higher lumen opposing process, but definitely Axios having more higher force than Spacious, so it can make a lumen position. So another point of Spacious is it can make some accommodable apposition according to the wall thickness of anastomosis like this. And also this video shows complete recapturing after deployment of, even after deployment of distal flange. So it's another advantages of Spacious. And it has 3 kinds of stent diameter for the purpose of drainage, like Waltham necrosis, gallbladder, and choledochord duodenostomy. So our group reported the first clinical result using Spacious for US guided drainage. And following Korean multicenter study and Asian multicenter study result shows a high technical and clinical success rate and very acceptable adverse event rate. The role of LAMS for Waltham necrosis is not only drainage, it can make some port for direct endoscopic necrosectomy. Let me show this case. This patient having a big one, and the US guided drainage using 16 millimeter lumen opposing metal stent is performing after deployment of distal flange on US and fluoroscopy, and proximal flange deployed on endoscopy. You can see the gush out fluorant drainages from the one. And then you can use Spacious as a port for endoscopic direct necrosectomy without removal of stent. And you can see the necrotic tissue here. So we are using many weapons like a snare and forceps, everything. And it's not easy work. And several trial of necrosectomy, you can see the pinkish backside the wall. It means a complete necrosectomy. US guided gallbladder drainage can be effectively performed using LAM, especially for malignant cyst duct obstruction. And let me show just a case, and you can see the cyst duct cancer invasion make acute cholecystitis like this. And all procedures same after puncturing and inserting guide wire, and distal flange is deploying on US and fluoro, and proximal flange is deploying on endoscopy. Now we are using intrachannel deployment, and you can see the Gaussian fluent bile. And amazingly, after deployment, a gastroscope is inserting into the target organ like a gallbladder through the stent. And you can see the fantastic surface of gallbladder and some cancer-like depressed lesion here, and MBI and white light image, and then make a tissue sampling on using forceps on direct visualization inside the gallbladder. So for this patient, after stenting, very severe acute cholecystitis, you can see there's some drainage tube from other hospital and some stones on direct visualization. You can see the MBI, and then now therapeutic intervention on direct visualization. Stone is removed from the lumen of gallbladder. Very effective using a lumen opposing metal stent like this. Also, US guided choledochord duodenostomy with Axios already reported. Let me show this case. You can see the obstructing mass lesion on here. Definitely pancreatic, huge pancreatic cancer. At first, we tried the US ERCP guided drainage, but we couldn't find the orifice of ampulla because of heavily infiltration by the cancer. So immediately we changed the scope echoscope and puncturing the dilated bile duct and guide wire. And then we inserted 8 millimeter of aluminum opposing middle stand spacious and immediately make a drainage using choledochore duodenostomy. And then we can insert the scope inside the bile duct, like a porocholangioscopy, and through the spacious. And you can see the luminal surface of the bile duct through the luminal opposing metal stand. Recent development of luminal opposing metal stand is a one-step puncturing and stenting using introducer system capable of electrocautery catheter. And it can make reducing very critical tract dilatation step. So procedure can be more easier. And heart Axios by the CAN was the first one having electrocautery enhanced delivery system for one-step EUS guided drainage. Also, Spacious is developed having cautery enhanced access catheter for one-step EUS guided drainage. Let me just case after puncturing guide wire inserting in the space of 1, and then electrocautery enhanced heart Spacious is directly introduced through the lumen and then deployed. The procedure is much easier than comparing with cold Spacious. Now we are developing a Spacious version 2, having smaller flange and short length of stent. It can make a higher apposition power. And amazingly, it's on 9 French delivery system. Delivery system is electrocautery enabled catheter. Let me show just a case. The same, heavy infiltration of pancreatic cancer, so we couldn't make a RSP guided biliary drainage. So after changing, puncturing and guide wire inserting, and then now 8 millimeter heart Spacious version 2 is on 9 French delivery system. It means a more easier puncturing using a thin delivery system. And now distal flange is deploying on EUS. And after intrachannel deployment, stenting was done nicely. And also we are developing a new bipolar electrocautery enhanced delivery system like this photo to reducing tissue damage and bleeding by electrocautery. So using the kind of bipolar system, we don't need the returning electrode plate on patient. So this video shows animal study using bipolar electrocautery enhanced delivery system. The procedure same, puncturing and then deploying the stent. And finally, you can see the nicely deployed bipolar delivery system on Spacious. Heparigogastrostomy is creation of new fistula between upper stomach and left intrahepatic duct. But it has some critical issues, like most critical one is fatal stent migration after stenting. So we developed a Spacious MG for EUS guided hepaticogastrostomy. It has a 20 millimeter proximal anchoring flange to complete folding bank to prevention of migration and each access put to bile duct. And you can see the nicely deployed proximal flange on here. Now let me show just a case. After puncturing of dilating B3 and then direct dilatation, and now newly developed EUS MG stent is introducing inside the bile duct and then deploying slowly. And after intrachannel deployment, you can see the endoscopic view. Now you can see the very nicely deployed proximal flange. So with the kind of development, you don't need the longer remaining part of stomach for EUS HGS. And And 1 week later, we tried to insertion of a 5 millimeter ultra slim scope inside the bile duct through the US HGS stent. And you can see the now nicely insertion of a small version of gastroscope inside the bile duct. Again, endoscopy view. Now you can see the deployed stent and inserting a scope inside the bile duct and carefully insertion. And finally, you can see the hilum and here. And from here, and you can make some good intervention through the metal stent even after US HGS. In conclusions, aluminum opposing metal stent can make effective and safe drainage and accessible route for interventional procedure through the gut wall. With the continuous development and improvement in metal stent, we can make a better success and safety and effectiveness for our patient. Thank you for your attention.
Thank you, Dr. Moon, for your excellent presentation.
Thank you for your attention. Thank you.
I think we can move on to the next speaker right away.
Okay, thank you.
I would request Dr. Randhir Sood to start his presentation. And we all know Dr. Randhir Sood, he does not require any introduction. He'll be talking on endoscopy in the COVID era. Over to you, sir.
That is a wonderful lecture, Professor Moon. Really enjoyed. Am I audible?
Yes, sir.
Perfect.
Yes, sir.
Perfect.
Okay.
It's perfectly okay.
My talk is, not based on too much of data. It is more on the evolution of the evidence as well as the philosophy which has happened over a period of last almost 13 months of our facing this epidemic. And I'm going to speak on the endoscopy in the COVID era, and more importantly, how are we going to get out of this situation, because the things are changing. So I'll straightway, tell you that globally, there are more than 91 million cases as of yesterday, and nearly 2 million deaths, which is tragic. And overall in the globe, there were 43 lakh new cases, 4,31,000 new cases yesterday, which means that pandemic is nowhere near dying in entire world. There may be better places, better spots in the world where the things may be in a recovery phase. Like in India, we had 10 million cases and around 15 lakh, 1,51,000 people died out of this disease. And we are over the peak in the early recovery phase. How do you define early recovery phases? That if for continuous 2 weeks, you have a decreasing trend of daily case volumes, then you call it that you're over the peak and it's a recovery phase which you're entering. Daily infections have come down from 15,000 to 15,000 from a peak of 98,000 at one point of time in August. And today in India, the active cases are only 2,13,000. So we are in a much better situation than in most part of the Europe and USA. And there's a consistent decline since 1st November onwards. The more important issue is that apart from the decline in the number of cases, two things are happening. Up to 20% of population in India possibly has already developed antibodies because of getting infected with the mild disease and not necessarily having been picked up. And vaccination drive is starting today. So it's the most appropriate time to talk about this issue in India. So we adopted the principles of endoscopy in COVID era because endoscopy, most of the procedures are aerosol generating procedures, which is a high risk and exposes healthcare workers to risk of getting infected. There was the issue in the beginning of PPE supply and cost, which continues to be an issue. But fortunately, because a lot of industry in India shifted to manufacturing of PPE, today we are in a happier situation in India where the supply of PPE is not an issue, but added cost to the patient or to the institutions remains an issue. Then another very important issue is that we never geared for a pandemic. Our endoscopy suites and facilities are made in a different fashion, and so our infrastructure cannot be changed overnight. And we also have a behavioral problem with our people. Now, none of our patients in India ever comes alone for an endoscopy, and they will come with at least 2-3 relatives, which adds to the total number of people entering the endoscopy area. So adopted strategy today is protect your patients and staff, minimize cross-infection, limit endoscopy to only urgent and emergency situations like GI bleed, cholangitis, and dysphagia. This was the guiding principle of early days of pandemic, particularly where the pandemic is still raging. So that was our, this was all according to the guidelines issued by European societies, Asian Pacific Society, AGA, ASGE, and even our own 3 societies jointly issued guidelines which were limiting the number of ERCPs being done and the indications and the precautions which we had to take. And what did it happen? What did it lead to? It had a huge impact on the in endoscopy data. If you look at the National Endoscopy Database of UK, the weekly endoscopies in UK in April fell from 35,000 per week at peak to 1,700 endoscopies. So just 5% of the endoscopy load was being done in UK. The Global Endoscopy Working Group, has done a survey which of 48 countries and 163 centers participated, and almost all centers reported less than 50% volumes being done during this period. This survey ended in August, and almost 2.5% centers even stopped doing endoscopies altogether. And upper GI bleed, lower GI bleed, and cholangitis remained the main indications. And 50% of the centers had COVID positive patients to scope, and 30% centers ended up with healthcare workers getting infected. So, in spite of all these guidelines, we still had significant problems at our hands. And this led to an indirect issue. Like patients were scared of coming to the hospitals because of fear of acquiring COVID infection. And there was a huge backlog of patients needing endoscopy, and it led to negative health impact. More patients are today at a risk of dying because of advancement of their malignancy, because we never detected it late, or their disease because it was not addressed earlier. Varicose screening went on the back burner. The colonic screening went on the back burner. So everything was delayed, and so it was the IBD. So this does lead to negative health impact, and we do need to rethink, because it is not a short pandemic. So, there are developments like vaccination happening. We have to have a strategy in place. How are we going to get out of it? So let me spend a few minutes on that. The restoration of endoscopy has certain guiding principles. The safety of the patient and staff remains paramount. So we cannot have some strategy which will put them at risk. And delay in diagnosis may lead to irreversible negative consequences. So we have to look at the new indications, expanded indications of endoscopy, even during interim phase. And safe COVID minimized environment is the key word. It is needed. And I'll come to that, how we can create that. We have to reallocate space, staff, personal protective equipment, and endoscopic equipment utilization. And this will limit the capacity utilization maximum up to 75% of the pre-COVID capacity. So for short period, you will not be able to go back to pre-COVID time. Maybe it will take few months more. And ramp up must be planned and phased, because infection status is not static. Today, we feel we are in a happier situation in India. Tomorrow, we may have another peak before the vaccination kicks in fully. So we should be ready for that, and we should have a strategy in place. Screening strategy may change with vaccination and infection status. So this has to be also a dynamic process, how to screen patients and which to screen the patients. So when we talk of reallocation of space and manpower, the most important added component to the endoscopy units is online screening and appointments. This was not being done by most of the centers, but we have to get used to it. The patients should not be going to the counter of endoscopy suite to take an appointment. We should be able to give them online appointment and encourage that. and to minimize the man-to-man contact and ability to transmit infection, and on-site symptom screen with the patient and before patient enters the endoscopy area, and then the facility for post-COVID, post-endoscopy surveillance. Now, how to create COVID minimized environment? This is by maintaining a safe linear patient flow. We should have endoscopy units which should have a separate entry and exit point. They should not be intermingling of patients who are coming in for endoscopy and who had endoscopy. That will minimize the person-to-person contact. And we should also identify patients at high risk because of their pre-existing comorbidities and prioritize their endoscopy in a fashion that they are not at risk of acquiring infection. And we should schedule our patients knowing very well that endoscopy throughput will increase due to enhanced infection control in process, because the room turnover will take longer time. And we should also be looking at creating a separate hot pathway facility for COVID positive or emergent high-risk patients, because there will be patients with massive bleed or septicemia due to cholangitis who will need immediate endoscopy before their screening test report comes in, and the symptom screening test will not be of value. So you have to accommodate them. So you have to create a time slot or a separate space for this kind of patient. Now, we should also be looking at non-invasive alternatives to certain areas where we used to use endoscopic procedure as a routine. These are like using CRP and fecal calprotectin for mucosal healing, using capsule endoscopy instead of invasive endoscopy, radiological investigations, when you're taking a decision between EUS and MRCP, these days MRCP may take precedence. Similarly, barium series for dysphagia, etc., etc. But we have to understand that their clinical and cost efficacy needs to be constantly evaluated, whether they can become a part of the future protocol. This is the most important slide which I would like you to concentrate on. This is what the British Society says 5S strategy. You stratify the patients, you screen the patient, you have separate pathways for different kind of patients. Then you have a separate provision of scoping them, and then survey the patients who have been scoped. So, let's look at which are the patients who are, the most vulnerable. We know that from even our own data, the most of the ICU admissions and deaths in India happened in patients who are more than 60. So elderly are at a high risk of having serious COVID infection. And of course, patients with pre-existing morbidity tend to be, having a higher morbidity and mortality due to COVID. There are a group of patients who are at a very high risk, which are the extremely vulnerable group. This group is the group with the solid organ transplant recipients, cancer patients, and patients with diabetes, severe obesity, COPD, and on immunosuppression, and in liver disease, like patients of autoimmune hepatitis on high-dose steroids, or ALD on steroids, or ALD as such, and IBD on high-dose steroids, or patients on immunotherapy. So these are the special, extremely vulnerable group, and we need to prioritize this. So this particular information lets you stratify your patient population so that you can decide on the time schedule or the patient endoscopy, care areas according to their vulnerability. Then we come to the the screen and scope strategy. This is the second S. This can easily be put in place by doing a symptom screening, which is SCOTS. Earlier it was, the fever, the travel, the occupation, contact, and cluster. And now it has been extended to symptoms, contacts, occupation, travel, and the shielded group, that is the severe vulnerable group. So this information is taken online 3 to 7 days before given the appointment. So you can stratify the patient, and COVID RT-PCR is done in all asymptomatic patients within 3 days of the procedure. This is our standard of care in our hospital also, that we never do a endoscopy on any patient who has not got a COVID RT-PCR done. And then Scots should also be done on the entry of the endoscopy unit, including temperature recording. And now coming to RT-PCR from nasopharyngeal secretions, it is till date the most reliable test to diagnose COVID. Its sensitivity may be just 70%, but certain studies show that it could be even up to 89%. But even at a conservative estimate of 70%, it still has a very high specificity of more than 98%. The most important thing is the negative predictive value. The negative predictive value of RT-PCR depends upon the prevalence of COVID in the community. If you have a prevalence of 3%, 10%, or 20%, the negative predictive value of RT-PCR will be up to 99%, 97%, or 93%. So if you have done Scots and the patient is RT-PCR negative, then the extremely low chance that the patient will be an asymptomatic patient who will give you infection. And let me tell you, in spite of the hype of very high numbers of asymptomatic patients, the data proves that not more than 20% patients are actually asymptomatic if followed up for subsequent 1 week or 10 days. The screen and scope strategy is essential for safe COVID minimized environment. So for screening, apart from this is the flow chart which I'm proposing. I think there is a noise coming on the background, I think from the center. So you do Scots screening by questionnaire 3 to 7 days before endoscopy appointment. If there are no Scots criteria, one scenario is that the center does not have facility for RT-PCR, and then you will do through the hot pathway and do with level 2 PPIs. Scenario 2 is that the no Scots criteria and test is negative, and then you have lower GI, you can use level 1 PPI. For upper GI, you still use level 2 PPI because it's a aerosol generating procedure. And if the RT-PCR is positive, if the indication is such, you can wait for 14 days at least and do it later. Or otherwise, you have to use it like a positive COVID patient through a hot pathway and using level 2 PPIs. If more than one Scots criteria is concerned, again, you use the same criteria that you can wait for 2 weeks and reassess the patient or go through the hot pathway, so that you separate out 2 streams of patients who can be taken off COVID minimized pathway or hot pathway. This is very important. And in the endoscopy area, the separation is done by linear endoscopy flow with separate entry and exit. As I told you, you must maintain social distancing because the problem is education of the patients and attendants and the nursing staff and the endoscopy staff, which needs to be very rigorously implemented. And the appointment system has to be staggered. Separate hot pathways and COVID minimized pathways can be done. Large centers can have different areas allocated. Like if you have an area with negative pressure rooms, you can make them into a hot pathway area and not mingle with the low risk patients. And or if you do not have the facility, you can use different timings. You do the COVID positive patients in a different time of the day and negative patients early in the day, or different days you can allocate. You only do positive patients on, say, 2 days a week, and rest of the day patients do rest of the week. And so that there's no intermingling of positive and negative patients or high risk patients with these, so that you minimize the possibility of cross transmission. So we come to the 4th S, which is the endoscopy. In the endoscopy room, we must minimize staff to 1 endoscopist, 1 nurse, and 1 technician. And in COVID minimized upper GI procedures, I told you, will still continue to be level 2 PPI, and that is PPE. That means that you will have to have a N95 mask, you will have to have water repellent gowns, and preferably a face shield. And for lower GI, you can use level 1 PPE. There's the surgical mask and just an apron. But hot pathway, always level 2. And all patients where oxygen saturation is more than 90 should be on a surgical mask before and after the endoscopy, after they have recovered and their saturation is above 90. One suggestion I have is that we should still maintain distance between the endoscopy personnel amongst themselves, because it's very easy when you're in a room with nothing going on, where people tend to be chatting and coming very close to each other. We should desist from that, because we can all transmit infection to each other. And as a protocol, maintain same nurse to do the per endoscopy and post endoscopy patient care, so that one person only gets exposed to one patient rather than 3 nurses getting exposed to the same patient, in case the patient happened to be asymptomatic carrier, asymptomatic patient who was not picked up with the SCOTS or RT-PCR. Now, just to recapitulate, all patients come with a surgical mask, no attendants allowed in the endoscopy area, counseling with social distancing, minimize number of people in the room. All should don proper PPI according to the level of care. Meticulous hand hygiene at every step. Prefer deep sedation to reduce aerosol. We use most of the times propofol these days. And keep suction when withdrawing the device from the biopsy channel, so that you don't have air bubbles coming out of the biopsy channel, and that can cause a possibility of spilling over. So that's another small trick which can help us. The most important thing is that after the endoscopy, you will need to have enhanced infection control protocol of cleaning the endoscopy area after each procedure, which will definitely reduce your throughput, but it is very essential when we are in the pandemic or early recovery phase. Education of the staff, according to me, is disease-related information, the proper PPE usage, both donning and doffing of the PPE and its appropriate use, and workflow issues should be discussed with the staff, and they should be educated about it so that we can get maximum cooperation. The surveillance is equally important, that post-procedure, all patients to be interviewed on phone for symptoms on day 7 and day 14. And if there is if they are present, then testing and contact tracing is a must. And the antibody testing of the endoscopy staff may actually become an important issue after the vaccination has been done. Then maybe we'll have a pool of safe staff who can be positioned to minimize the risk to the patient. But we still do not know the protective value of the of the presence of antibodies in a person, but that evidence and knowledge will evolve over a period of time. So this is my summary slide, that we have pandemic, early recovery, and post-pandemic time. So protection will be that during the pandemic, screening is not an issue because everybody will need to be treated in the same way, and high-risk PPE is to be used in each patient. In early recovery, stratified PPE, as I mentioned, after RT-PCR study and the SCOTS analysis, and screening should be done on telephone and testing accordingly. And when we are coming into post-pandemic phase, then we will be gradually going back to our pre-pandemic situation. But I will say that even after the pandemic dies down, we should be having at least 3 months to 4 months of period where we should be extremely cautious that there may not be resurgence of the infection. Procedures during the pandemic, we restricted to emergencies with intensive infection control. And early recovery, which is now in India, we should start with phase 2 indications, and we should continue with stratified infection control policies according to the minimized COVID corridor and hot pathway. And subsequent to when the post-pandemic period comes, then we go back to the pre-pandemic protocols, but with new knowledge learned, because we may have continue to adopt certain policies which will help us mitigate communicating other infections rather than COVID to our patients and to our healthcare staff. And as far as the unit is concerned, during pandemic, a lot of staff and the areas were given away, repurposed for care of the COVID patients, and so there were very little administrative burden because we were treating a particular disease, and endoscopy was not a priority. In early recovery, we will all recover back our endoscopy suites, and staff will also be reclaimed from the previously allocated responsibilities. And this will keep on increasing the administrative burden, because now we have added online appointments, online screening, and surveillance to our daily routine of endoscopy. So that will increase the burden of administrative staff. Subsequently, we will, when we go to the post-pandemic, the full cadre of staff will be recovered, and we will start doing all the procedures gradually. And what will happen is that this will, happen over, according to my estimates, over next 6 months period of time. Thank you very much for patience.
So can I ask one question to Dr. Sood?
Yeah, sure.
Sir, in a patient who is COVID positive,
Yeah.
we take all precautions using a PPE kit, but
Yeah.
what about the accessories which are used in that patient? Should it be disposable or can we reuse it after sterilization?
Your sterilization protocols do not change because COVID is not a very hardy virus. It's just like HIV protocols we had for patients. It's only that you have to be protecting against aerosol and droplet infection for yourself and for your staff, and subsequently endoscopy sterilization, device sterilization, whatever your institutional protocol is, we should follow that.
Thank you, sir. Thank you. Can we
So
proceed?
can I have another question for Sood?
Yeah, Nitin.
Sir, there was a study about a few months back, the post-ERCP pancreatitis being probably higher in COVID positive ERCP patients. Do you have any,
See, we had no personal experience of ERCP in COVID positive patients in our institution, so I won't be able to give you any answer from my experience. We did see pancreatitis in some patients of COVID in our wards, but the incidence was not unduly high. In fact, many of them were termed as possibly COVID-induced, but I don't think COVID has much to do with pancreatitis.
Thank you, sir.
Thank you. And can we shift to the next speaker, please?
Thank you.
Thank you. Can chairperson introduce to the next speaker?
So I would like to invite Dr. Pramod Garg. Is he there in the session, sir? Dr. Pramod Garg? I'm not seeing him on the, okay. Professor Kida. Okay. I'd like to invite Professor Kida for the next talk. And
Dr. Pramod Garg is there. Dr. Pramod Garg is there.
Sure, we are there. Sorry, sir. I would like to invite Dr. Pramod Garg for the next topic. And his presentation today is on indeterminate pancreatic head masses, role of EUS, how to approach. Over to you, sir.
Thank you, and very good morning to all the chairpersons, moderators, and faculty and audience. I'd like to thank the organizers, in particular, Dr. Rajesh Puri, for having given me this opportunity to talk this morning about indeterminate pancreatic head mass. This is a problem which is often encountered in our day-to-day practice. So if you have a patient like this, a 61-year-old male comes with abdominal pain for about 3 months. He has lost 15 kgs of weight, recently detected diabetes. The only differential you would think of is CA pancreas. And if you do a contrast-enhanced CT scan, it shows you a large mass here, which of course clinches the diagnosis. And if it is particularly involving the vessels, you know diagnosis is not a problem. Most patients, in fact, do not require FNA. FNA is required if you plan chemotherapy or the relatives want a definite diagnosis. The yield of EUS guided FNA is obviously better than CT guided FNA, and that is what is done today in majority of these patients. But prognosis, of course, remains poor in these patients. So as far as the diagnosis of such a pancreatic head mass is concerned, that is not a problem. So if you have to approach pancreatic head mass, we have to see the setting. And the setting is important, whether we are seeing a mass de novo or we are seeing a mass with an underlying chronic pancreatitis. And the reason I bring in chronic pancreatitis is that this is something that we see very often, and these patients also present with a mass in the head of pancreas, which creates more of a diagnostic problem than a de novo pancreatic mass. So in de novo pancreatic head masses, the starting point is that it is cancer. It is neoplastic, unless proven otherwise. So this is very important to understand, that regardless of my imaging technique, regardless of what I find on other things, the starting point is cancer. I'll give you two series. One is a surgical series where patients underwent Whipple's resection, and only about 10% of these patients were found to have non-neoplastic lesions when they were operated for suspected pancreatic cancer. Another series of 494 patients. This series included EUS as a pre-operative workup, and only 7% of patients were found to have benign disease. That means more than 90% of patients who present to you with de novo pancreatic head mass will have pancreatic cancer. So most of the time, we should think that that is the diagnosis. The question comes in, when do we suspect in a de novo pancreatic head mass that it could be benign as well?
I think there must be some connectivity problem. We can wait for 1 minute. Dr. Pramod Garg will joining soon. Yeah.
So the other is on imaging, we find that there are certain characteristics which suggest it could not be, that it is likely to be benign disease or not pancreatic cancer. For example, we have a cystic lesion when we find that the entire pancreas is bulky or the main pancreatic duct is not dilated. So this is an example of a 30-year-old male who presented with abdominal pain for 3 months, and he had some low-grade fever. CT and MRI both showed a pancreatic head mass with a liver SOL. The moment you have a liver SOL, you think it is likely to be a malignant disease. But here the odd points were that he was a young patient and had also history of fever. And you can see he had a pancreatic mass in the head and also a liver SOL. He underwent an EUS, which is the standard modality to diagnose these patients, cytopathology. And on EUS, we found a mass in the head of pancreas. A FNA was done, as is the usual practice. And what we found was that the patient had tuberculosis. We could see acid fast bacilli on the aspirate, and that proved the diagnosed tuberculosis. So the reason I'm telling you about this patient is that a young patient who presents with fever, we should suspect it could be a benign disease. Now the context changes from a younger person to an elderly person. In elderly persons, I've told you that if you have a de novo pancreatic head mass, it is CA unless proved otherwise. Let's be very clear about it. Whatever your CT, your EUS, your MR shows, you take it as malignant, of course. If you do EUS, the sensitivity of FNA is around 90%. There are reports of sensitivity being as low as 70%, and there are reports of sensitivity being as high as 95%. But I would say if you take across studies, it is around 90%.
Okay,
now what is worse? Suppose you have a patient in whom you operate, 10%, I've shown you two series, 10% are found to have benign disease. Or you do not operate 10% who are malignant because your sensitivity is 90%. So if you base your decision on FNA alone, then you are likely to miss 10% patients who are malignant disease. So overall, it would be okay to operate patients without a diagnosis. And that is what many of these guidelines, including ESG guidelines, have shown, that if you do not plan, for example, a neoadjuvant chemotherapy, there is no reason to do FNA before you proceed for surgery. In a resectable lesion, of course. This is very important to understand. Now, sometimes you find that there are odd features here. For example, this patient came in with 77-year-old male presented with jaundice for 3 months, anorexia, weight loss, diabetes for 5 years. Classical setting for a CA pancreas, and that is what the imaging showed. He had a dilated CBD, pancreatic head was enlarged. He underwent ERCP and found to have a CBD stricture. Stenting was done, diagnosed CA pancreas, and then he was referred to our institute for further management. When we evaluated this patient, we found on EUS, which is now almost a standard test to do in patients who have got any malignant pathology, because most surgeons will like to have an EUS before they operate. we found the pancreas was diffusely enlarged and hypoechoic, and most importantly, MPD was not dilated. There was no clear-cut mass was seen, and that's raised the suspicion of autoimmune pancreatitis in these patients. So again, he underwent EUS, which showed a diffusely hypoechoic enlarged pancreas, and further MRI was done, and you can see here that the pancreas is diffusely enlarged with a halo around it, classical picture of autoimmune pancreatitis, and he also had autoimmune cholangiopathy associated with it. Serum IgG4 was of course increased, and thus we made the diagnosis of autoimmune pancreatitis. Patient did well with medical therapy. The context now changes from de novo to a patient with underlying chronic pancreatitis and a mass lesion. Now, in such a situation, what do we do? So the question here is it a malignant mass or is it an inflammatory mass? So another example of a 42-year-old male came with history of pain in abdomen for 6 months. He had jaundice for 2 weeks, weight loss, but no fever, and he was a chronic alcoholic. So this is a setting of chronic calcific pancreatitis. This is what CT scan showed, but it also showed a head mass in addition. CA19 was also raised. So of course, there is a strong suspicion of malignancy here. So what do we do next? So we ended up doing a EUS, which is again, as I said, is the usual case in these patients. So EUS showed that the pancreatic head is enlarged. There are multiple calculi. CBD was dilated, and there seemed to be a ill-defined lesion in the head of pancreas. So the other thing one could do is a contrast EUS and also FNA. So in this particular patient, if you see here on the left side, there seemed to be an ill-defined mass, but multiple calculi were seen inside this. So there are some areas where we suspected it could be malignant. And then a contrast EUS actually showed that the lesion lighted up on contrast EUS, which suggested it is likely to be inflammatory mass rather than a malignant mass. And then you do FNA in these patients, and FNA in this particular patient showed a benign pathology rather than a malignant pathology. So this is a situation where EUS actually is very, very helpful. You can see once again that there is a suspicion of a mass here, but then it lighted up on contrast EUS. The other thing is that if you find the main pancreatic duct inside the mass, that's a very, very important sign, both on MRI, where they call a duct penetrating sign, or on EUS. If you find your MPD is going through the mass, it is most likely a benign mass rather than a malignant mass. And also, if you start seeing calcification also within the mass, it is most likely inflammatory. So these are two important features on EUS to say it is likely to be inflammatory pathology. Now, this is another patient who is 36-year-old, and she is a young patient. And she presented for pain for 6 months only. Mind you, it's pain only for 6 months. But she was a diabetic for 5 years. And CT scan showed features of chronic pancreatitis with a head mass. And this is what was confirmed on EUS also. And the final diagnosis made of idiopathic chronic pancreatitis, which is mostly genetically determined in our patients, with CA pancreas. So to understand this issue of CP and CA, we did two prospective studies. One was a cohort study of 402 patients with chronic pancreatitis. The mean age was 29 years. Mind you, most of our patients are young when they present with chronic pancreatitis. 309, majority of them were males. They were followed up prospectively. And we found that over a follow-up period of 3,879 person years, 57 patients presented with a mass in the head of pancreas. Malignancy on imaging was suspected in 31 of these patients, and ultimately 5 of these patients were diagnosed to have pancreatic cancer. That means about 10% of those who presented with a mass lesion. The mean interval from the onset of pancreatitis to diagnosis of CA was 16 years. And please remember this figure of 16 years. 4 had idiopathic CP and 1 hereditary pancreatitis. That means none was alcoholic pancreatitis here. We did another study, that was a case control study for risk factors of pancreatic cancers. And in this, we included 249 patients with pancreatic cancer, 1,000 healthy controls. And we found 24, almost about 9.5% of these patients had underlying chronic pancreatitis. And all these 24 patients had idiopathic chronic pancreatitis. And the risk factors for CA in this case control study were chronic pancreatitis with an OR of 123, diabetes of more than 4 years duration with the OR of 2.9, and smoking 2.08. So in both cohort and case control studies, none of the patients with alcoholic CP were found to have CA pancreas. Now, this is an important point to remember, and I'll tell you why. So from chronic inflammation to cancer, there is obviously a long delay. The interval between CP and cancer in our series was 16 years. And if you look at any other disease, IBD to colon cancer, cirrhosis to HCC, Barrett's to esophageal cancer, you find there is a long delay there. The mean age of patients with alcoholic CP in our series is 38 years. And that's what across studies around 40 years is the age. Now, age at diagnosis about 42 years. So if at all, these are the patients who will develop cancer, they should be having the disease for 15 years or so. So at the age of 55 to 60 years, they may have pancreatic cancer. Not in the beginning when they present with chronic pancreatitis, right? With a short history. So patients with alcoholics, and they are mostly smokers as well, they're not immune to develop CA pancreas. So they can develop pancreatic cancer de novo, right? That's important. But they may also develop chronic pancreatitis at the age of say 40 years. Now from here to go to CA pancreas, they will take at least 15 to 20 years. So the point is that if you have a patient with chronic pancreatitis who is alcoholic, who comes to you at the age of 40 years, and you find there is a mass in the head of pancreas, if he has chronic pancreatitis, it is not chronic pancreatitis to CA, it is most likely inflammatory mass. So someone who consumes alcohol is not immune to develop pancreatic cancer. In fact, the risk is increased because of associated smoking in them. So ladies and gentlemen, I would like to summarize by saying that if you have a pancreatic head mass, we should take it as malignant, regardless of the context. We should operate if it is a resectable lesion. FNA is not a must to diagnose CA, unless you plan neoadjuvant chemotherapy. We should suspect it to be a benign disease if you have a young patient, if you have a patient who presents with fever, if you find on imaging the MPD is not dilated, and I think this is a very important feature, or there is a diffuse swelling rather than a discrete mass in the head of pancreas or anywhere. Or if you have a patient who presents with alcoholic chronic pancreatitis with a mass, it is more likely to be inflammatory than malignant. And EUS, to my mind, is the best diagnostic test for evaluating pancreatic masses. Even after CT and MR, we end up doing EUS in majority of our patients, and often with FNA. Thank you for kind attention, and we'll be happy to take questions if we have any.
Thank you, Dr. Pramod, for that excellent coverage of the topic. If we have some pressing questions, we can take.
Can I ask you a question, sir?
Please do. I finished my talk in 17 minutes, so you have 3 minutes with you.
Suppose you have a chronic pancreatitis with a mass and where you're suspecting it to be malignant based on radiological or features or elevated CA19-9, but your FNA turns out to be negative. So how would you follow them up? Would you like to repeat an FNA immediately, or maybe follow them up for imaging or repeat FNA few days later? How do you go about it?
So the starting point I told you, if a patient with pancreatic head mass, I suspect malignancy, I don't do FNA. I will send the patient for surgery. Now, if the surgeon asks me that I want to do neoadjuvant chemotherapy, I will do FNA. If that FNA is negative, I will repeat FNA, right? That's the plan, if the neoadjuvant is planned. I'll do FNA if I suspect that it is unlikely to be malignant. And I've shown you some features where we think it is likely to be benign, and I'll do FNA. So for example, if chronic pancreatitis alcoholic comes to me, the FNA is negative, I don't repeat FNA because I think it is likely to be inflammatory. But if an idiopathic pancreatitis comes to me, I find there is a mass, it is likely to be malignant, I don't do FNA, I will say straight away for surgery.
Doctor, if the FNA is negative, is there any point of doing an FNB in these cases?
No, that is fine. Again, Now, you are entering into the another debate, FNA versus FNAB. The indications of doing FNA or FNAB remain the same. That means when I think it is likely to be benign and I want an FNA, I will do FNA or FNAB. And currently with the available very good needles, FNAB needles, most of the time we are doing FNAB rather than FNA. Okay?
So Dr.
But
Pramod,
the other things will remain the same.
Dr. Pramod? Okay, Rajesh. Okay.
can I ask one question? Dr. Pramod? Dr. Pramod? Huh?
We have lost connection.
Dr. Pramod, your microphone is off. So I think we should shift to the next talk because now the time is over. And next talk is by Dr. Kida. The panelists can invite the next speaker, please.
Yeah. So the next talk is role of IDUS in clinical practice, and it's by Professor Mitsuhiro Kida. He is professor in the Department of Gastroenterology, Sato University, Japan. So, Dr. Kida, please.
Okay. Thank you, Chairman. And ladies and gentlemen, first of all, I would like to express my sincere appreciation to Professor Sood and the organizing committee. I will talk about the role of IDUS for the video pancreas disease today. So there are several routes to do the IDUS: ERCP route, PTCD route, intravenous route. This is the indication of the IDUS. Diagnosis of the bile duct stone and especially the residual stone. Diagnosis of the cancer depth and the lateral extension of the bile duct cancer. And also the evaluation of the bile duct irregularity and also diagnosis of the IPMN. These IDUS probe, which has a 20 megahertz transducer and 2 millimeter in diameter. Those are thinner than the probe for the GI tract. Using guide wire, it is practicable to insert the IDUS probe into the intrahepatic duct as you like. So this is a typical anatomy of the biliary system. This slide shows the right and left hepatic duct and portal vein. This is the second step. This slide shows the right hepatic artery across between the portal vein and the bile duct. This slide shows the cystic duct depart from the bile duct. This slide shows the intrapancreatic bile duct. MPD is now approaching to the bile duct. This is the duodenal papilla. Arrow indicates the OD. ERC shows the filling defect, and IDUS reveals the strong echo with acoustic shadow, which is bile duct stone. This is the differentiation between the bile duct stone and air bubbles. Air causes round artifact. Bile duct stone is demonstrate strong echo with acoustic shadow, like this. ERC shows the round filling defect suspect to be bile duct stone. However, I just show the air bubbles, then we can avoid the ESD. Can you identify the bile duct stone? IDUS detects the small bile duct stone. After ESD, we remove the small bile duct stone. In general, bile duct stone were overlooked in case of the large bile duct, more than the 15 millimeter, about 30%. And residual bile duct stone were overlooked in case after the using EMR, about 40%. This is the size of the residual stone that were detected by the IDUS. 3 to 6 meter bile duct stone were frequently overlooked by ERC. After checking by the ERC, residual stone were detected in 23% by IDUS. Concerning about the bile duct stone recurrence, the recurrence rate was 30% in the non-IDS group, but IDS group is only 3.4% with a significant difference. This is the multivariate analysis. Bile duct stone recurrence without IDUS case were likelihood of the recurrence, same as the cholecystectomy and lithotripsy. Summary. 1. It is practicable to differentiate the bile duct stone from the air bubbles. Using IDUS, it is superior to diagnose the residual stone compared to the ERC. The recurrence rate after the removal of the bile duct stone decreased by the IDUS. Bile duct was detected the 3-layer structure by IDUS. First and second layer means mucosa and fibromuscular layer. Third layer correlate with the subserosa and serosa. This is the local staging of the bile duct cancer. Tumor limited to the one and the first and second layer means T1 and T2. Tumor embedded to the third layer means T3, subserosa, and the tumor directly embedded to the portal vein, proper hepatic artery means T4. IDS reviewed the bile duct tumor, which is limited to the bile duct 4. Then we diagnose the T1 or T2 invasion. However, there is a tiny invasion to the pancreas that is diagnosed pancreas 1. Outer layer of the bile duct was interrupted by the tumor, not embedded to the portal vein. And then this bile duct cancer was diagnosed as subserosal invasion. According to the literature, the accuracy of the IDUS is 85 to 88%. Dr. Tamada reports IDUS proved useful for assessing the extension of the bile duct cancer invasion into the right hepatic artery, but not for the proper hepatic artery and the left hepatic artery. And also, Dr. Tamada reported the IDUS proved the usefulness for assessing the extension of the bile duct into the portal vein, even in the proximal bile duct tumors. So, IDS reviewed the bile duct looks normal in this part, right and left hepatic duct. The second, at the liver hilum, irregular thickening of the bile duct has started. Approaching to the main part of the tumor, bile duct thickening is increased. This is the main part of the tumor. The tumor embedded to the subserosa. Pancreas bile duct looks normal. It seems to be no extension to the pancreas. This is the accuracy of IDS on the lateral extension of the bile duct cancer. Its accuracy is around 68 to 92%. Summary 2. IDS has becoming a promising modality for assessing the bile duct cancer depth, but there is a limitation due to the attenuation. IDS could also assess the lateral extension of the bile duct cancer. However, combination of the CT and IDS is essential for the accurate preoperative staging. What is your diagnosis? Bile duct cancer is suspected. This is the border of the tumor, still thickening of the bile duct wall. Bile duct thickening is reviewed at the normal part of the ERC. The thickening is symmetric and homogeneous. This is IgG4 related sclerosing cholangitis. This is the differentiation between the bile duct cancer and IgG4-SC. Bile duct cancer is asymmetric and semicircular, irregular, heterogeneous. On the other hand, IgG4-SC is a circular, symmetric, homogeneous and smooth and clear margins. This is the differentiation between the PSC and IgG4-SC. IgG4-SC has a symmetric, smooth inner margin, clear outer margin,
Dr. Puri is
homogeneous,
requesting you should come.
and preserved this
Dr.
appearance.
Puri is requesting.
And for the PSC, diverticulum-like irregular lesions. So there is a stricture at the interhepatic duct as well as the distal bile duct. The IDUS review, the semicircular asymmetric thickening of the bile duct is reviewed. This is primary sclerosing cholangitis. This is a summary of the intra-IDUS findings between the PSC and the IgG4-SC. IgG4-SC is characteristic of the symmetric, homogeneous, smooth, clear margins. On the other hand, PSC has the asymmetric, irregular margin and the diverticulum findings. For the pancreatic region, IDS could reveal the mural nodule in the IPMN case, like this. Arrow indicates the mural nodule. This is still at the normal levels. This is also IPMN case. The arrow indicates the mural nodule. Carcinoma was diagnosed by the histology by IPMC. This is diagnosed IPMC. Using 3D IDUS, we can evaluate the radial image as well as the reconstructed linear image like this. Pancreas cancer embedded into the bile duct and interrupted MPD. We can see the both findings at the same time. So, summary 3, IDUS could assess the differentiation bile duct disease. IDS could assess the differentiation of the bile duct IgG4-SC and also the could differentiate the IgG4 from the PSC. IDS could evaluate the mural nodule of the IPMN. Thank you for kind attention. Okay, Rajesh?
Yes, sir. Yes, sir. So the question to Professor Kida is, what precautions you will take while using IDUS? While using IDUS, what precautions you are taking because it is a costly equipment?
Yeah, and at first, as you know, for the cytology and the histology of the biliary system is not satisfied. So therefore, I would like to do the many diagnostics too. Then I would like to summarize the final diagnosis, and also as I present my slide, especially the IgG4 is very typical pattern of the IDUS finding, and also for the residual stone, it is very sensitive. Compared to the ERC, and also you can identify the air bubble from the bile duct small stones. So then we can avoid the unnecessary EST. So therefore, the IDUS we employ the IDUS, and also of course we perform the cholangioscopy, baby scope as well. But concerning about the maneuverability, IDUS is more easy compared to the cholangioscopy.
And the question from the audience is the IDUS and mini probes both are same or they are different?
Pardon?
IDUS and mini probe, are they same or they are different?
I cannot catch.
IDUS and mini probe, are they both same or they are different?
Yeah, there are two types of the mini probe. The one is for the GI tract. GI tract for the probe for the GI tract is 2.4 millimeter in diameter, and IDS is only 2.0 millimeter in diameter and with a low pay system. So that this is a little bit thinner, and but of course that means more fragile than the GI probe.
Another question from the audience. For the longitudinal length of the cholangiocarcinoma,
Yeah,
will you prefer cholangioscope or will you prefer IDUS?
I prefer the both, but of course there is some case of only the very superficial spreading case, but in this case only the cholangioscopy can identify. But in general, most of the case has a thickening of the bile duct wall. In the most of cases, we can evaluate by the IDS only.
Okay, thank you, Professor Kida. Thank you for the excellent lecture.
Yeah, thank you.
Thank you.
Thank you for kind invitation.
Thank you. Thank you.
Right.
And can chairperson invite the next speaker, please?
I would like to invite Dr. Sandeep Laktakia for his next talk, and the talk is how do I do radio frequency ablation EUS guided. Over to you, sir.
Thank you very much. Can you see my slide and can you hear my voice?
Yes, we can.
Okay. So Nitin, good morning everybody, and
We can
The
hear your
slides are not
we
available.
can hear your voice, but we can't see your slides.
okay, just a minute. Can you see my slide now?
Yeah. Yes, absolutely.
At the outset, I would like to thank my friend Dr. Rajesh Puri and the entire Medanta team for hosting this fantastic conference in this testing times. And as you see the screen, I'll be speaking on an EUS guided RFA, how I do it. In this series of lectures of how I do it, this is one of the EUS procedures which is trying to find its place. It's still not widely available and an accepted modality of treatment. That's my disclosure right in the beginning. But having said that, why it should come slowly but surely in the algorithms of various treatment modality, we can take a call. So in this talk, I would be covering the types of devices that are used for EUS RFA. How is it done? The precautions to be taken, and what are the adverse events associated with EUS RFA. So currently, EUS guided tumor ablation is one of the indications, and this is an expanded indication of EUS intervention. As I said earlier, it's not accepted modality as a first-line therapy, but generally a fallback option when patient is not eligible for surgery. But why EUS? Because EUS provides a good anatomical access for local therapy. We can see the pancreatobiliary tree from very close quarters. And since we can accurately position our several devices for other interventions, including FNA and other devices, we can also deliver energy and ablate the tumor. So it's quite feasible now, and it's fairly safe. And the potential applications of EUS RFA is in the pancreas for pancreatic neuroendocrine tumors, both functional and non-functional tumors, or adenocarcinomas to reduce the size. It's a palliative treatment, and also for pancreatic cyst where it can be used for ablation. For liver, HCC, we know RFA is used percutaneously for several sites in the liver, but some of the sites are quite deep and not easily accessible by a percutaneous means, either ultrasound or CT guided, and such lesions can be accessed by EUS. And same goes for liver metastasis, say from colon cancer and isolated metastasis. And also solitary metastatic lymph nodes can also be ablated. So these are some of the indications where EUS has been tried and reported. I'll be mainly limiting to pancreatic tumor ablation, and it's considered for, as I said, in cancer because it carries a very dismal prognosis. And trying this modality helps in kind of debulking the tumor, which reduces the pain. We cannot cure the patient, but at least we can reduce his discomfort. But for pancreatic cyst neoplasm and pancreatic neuroendocrine tumors, surgery is a standard modality of treatment, but it carries significant morbidity even with surgery. for both the lesions. And EUS guided therapy can provide a less aggressive and an equally beneficial result, if not better. So how do we do it? So before I start, just one slide on the physics. It's a high frequency current, alternating current, which is passed through the device, which is a needle kind of a probe, looks like an FNA needle. And this heat, which is provided at the tip of the needle can vary from 1 centimeter to 2 to 3 centimeter, depending on what type we are using. This heat causes controlled coagulative necrosis, and that burns the tumor. So it's minimally invasive, safe, and well tolerated. And there are two different types of devices, as I've explained sometime earlier in our lectures, is that there's a through the needle device, which means that you pass an FNA needle into the lesion, solid or the cystic lesion, you withdraw the stylet, and then through the hollow of the needle, you pass the RFA device, which is like a guide wire. The whole guide wire is insulated except the tip, which is about 1 centimeter to 2 centimeter non-insulated, and that gives the heat. Whereas the FNA needle type device is almost similar to a regular FNA needle, but it has entire insulation and entire length except for the terminal 1 to 2 centimeters, depending on the type of device that you're using. They can be either monopolar and bipolar, and as the name suggests, you need a grounding pad in monopolar and do not need one in the bipolar. And some of these devices have an sophisticated internal cooling mechanisms, which is connected to the generator. The internal cooling mechanisms helps in preventing charring of the electrode tip. So whenever we heat, the tumor gets charred, and that can get adhered to the tip of the electrode, and then further heat transmission is not so controlled. So if you cool it internally, it looks very peculiar that you are heating as well as cooling, but the heating is from outside and cooling is from inside the needle. So these are the three of the commonly used devices. The left one is called Habib EUS RF probe, which is a through the needle device. This is the needle, and through that, this wire type device is coming out. It's 1 French in caliber, which is entirely insulated except the terminal 1 centimeter. So this 1 centimeter is which is giving the heat to the area in which it is enclosed. So be it cyst or a solid lesion. The most commonly used device is USRA or StarMed from Taiwan, Korea. It has a separate generator. This is the needle handle, which mimics almost the FNA needle. And these are the tips of the needle, with the blue one is a sheet. The inner part is the needle probe, with the yellow part is the insulated part, and the tip is the non-insulated part. So depending on how much you want to project out, it can vary. This non-insulated part can vary from 0.5 to 1 to 1.5 and 2 centimeters. And the third sophisticated device is hybrid thumb probe from Irby, which uses a conventional Irby generator. This probe is a little more thicker and passes through the sheath. It is about 11 French in caliber, and inside is even more thicker. So this is 3 centimeter long. That's the major problem with it, that the tumor has to be at least 3 centimeter in diameter to exactly encompass this device. So through the needle device is the Habib RFA probe. Bipolar is the hybrid thumb from the Irby, and two of them, that is hybrid thumb probe and RFA from USRA from Korea, has the internal cooling mechanism. Although the cooling mechanism is a little different. Carbon dioxide is used for Irby and cold saline for RFA from USRA. I'll just run this cartoon movie here to show how it works. So use an EUS, locate the lesion, then pass this device through the accessory channel, enter the lesion. Mind you not to overshoot, just stay within, and then with a press of paddle, the heat which is generated from the generator reaches the tip, and that ablates, which you can see real time on EUS. So this is the Habib probe, which I spoke about, and there is experience in the early part that we had, a solid tumor being burnt here. In this, you have to pass the needle till the end, then withdraw the stylet, and through the stylet you pass the wire, and gradually keep pulling back the needle while pushing out the wire. On the left is a cystic lesion which is being ablated. So first you aspirate the cyst first through the hollow of needle, and then you pass the wire. The cyst is being aspirated, it becomes dry here, and then you stay in the far end, and when the needle, when the wire projects out, then you keep pulling it back. So you have to keep a check on the fluoroscopy, which will show you how it looks like. Sometimes in a cyst, it can take a little bit of curvaceous contour, but in a solid lesion, generally it's more straight. And the amount of wattage that we use is 8 to 10 watt. Moving forward, this is the hybrid thumb probe which I showed earlier. So it is 14 gauge, the probe, but inside the sheath is 18 gauge and the probe is 14 gauge, which is much, much thicker than what we have conventionally. FNA needle, that is 19 gauge is the thickest. And the length of the active electrode is about 3 centimeters. So that's a major issue. And that's why currently it has been withdrawn to work upon it and make it a little shorter. So hopefully in next few months to years, we should be getting the modified version of hybrid thumb. And this is one of the cases that we had done a long time back of a pancreatic adenocarcinoma, where you pass the entire length of the active electrode inside and then burn the tumor by pressing the paddle. Since it is a bipolar electrode, the safety is there because the heat remains very close to the electrode only. It jumps from one electrode to the other electrode, which is nearby. And you can actually see these white bubbles which are coming up is heating happening there, causing coagulative necrosis. This has been shown to have some benefit in reducing the tumor size and in fact making some of the tumors amenable to surgery. The last but not the least is the most commonly used electrode worldwide is USRA. This comes in both 18 and 19 gauge, and the tip length of the active electrode is 0.5 to 1 to 2 centimeters. And this is the sheath. This is the insulated part which runs all through inside, and this is the active electrode. It looks like an FNA needle, and this has been used both for pancreatic adenocarcinomas, where it has been found to reduce the pain, and it is feasible. It's basically debulking the tumor. It's a large tumor here, and you can go in different directions just like fanning and burn in different areas. And this is the tumor seen one day later where you see a lot of necrosis that's not enhancing. Anyway, the pancreatic adenocarcinoma don't enhance. And after 2 months, the stent, metal stent, which was there earlier still remains, but the tumor is hardly visible. So it debulks the tumor. But most commonly it is used for NET. And I just want to explain the principle of how we use this. Imagine this is a tumor. This is a pancreatic duct within the pancreas, and this is the stomach wall, and this is the tip of the EUS probe. So this neuroendocrine has to be burnt by an RFA. So before doing it, since it is very close to the pancreatic duct, if you burn it, we can also burn the pancreatic duct. So there are 2 principles that people use is to prevent pancreatitis from RFA, either to place a prophylactic pancreatic stent, which is seen here, that even if the duct gets burnt, the stent prevents the severity of pancreatitis or prevents pancreatitis altogether. So you pass the needle to the far end of the lesion, preferably in the most difficult access line. So here in this cartoon, this is more difficult and this is almost impossible to reach. So you go down and then keep pulling back at different areas. So burn one area, stay there for 10-15 seconds, then pull back, burn the other area, and burn the third area, keeping the PD stent inside, which is placed 1 or 2 days before. And then after you burnt one area, then you go to the second area, which is more distal now. And there you can burn 2 areas depending on the vertical length of the tumor. So that's the basic principle in the cartoon fashion. And same thing we'll show in a video format here. This is a neuroendocrine tumor, insulinoma in a patient. You can see the electrode here, and once you press the paddle, the bubbles start appearing about 10 to 15 seconds later. The moment you see enough bubbles, you stop the paddle. So the heat generation then stops. Then you pull back a little bit more, burn another area. This area is still left behind, so you make another pass in this direction and then burn same way another part. It has a very sophisticated generator where you can see the impedance and the temperature also, how much it's going on. Let me show some more examples of pancreatic neuroendocrine tumor undergoing RFA. This is a head lesion, a large one, very, very vascular as you can see it here. The scope is in short position because the needle is a little thick. So here it comes. And we start from the far end of the lesion. We're using a 1 centimeter probe, which can be seen very nicely. And then once we have burnt one area, we pull back to the mid segment. And this way, many areas of the tumor can be burnt. Since the tumor is 3-dimensional and we have a 2-dimensional view, we need to torque the scope after withdrawing the needle to see which are the unburnt area and then burn under vision. So these bubbles will tell us which is the area which is left behind. And the effect of RFA actually continues even after the index procedure has been done. So the heat keeps going on and the coagulation necrosis at the periphery of the lesion also happens in few days to weeks time. And that's why the tumor shrinks in size. Tumors which are very close to the pancreatic duct, obviously, as I said earlier, the risk of pancreatitis is there. And as you can see, we have placed a PD stent in the lesion again in the head, which is quite close to the portal vein. See that the stent is just almost inside the tumor, it looks like that. And below is the portal vein. So there are two vital structures which have to be avoided. And one of them at least PD stent would avoid. This is a fast forward video and that's why you'll see it. But the principle remains the same. Go deep, come back a centimeter by centimeter, but remain within the tumor. Do not burn the normal pancreas. That's a dictum. Even if it is you underdoing the burning, it's better because some of the burning would happen later on as the peripheral zones or the penumbra of the lesion gets burned. So what are the complications of EUS RFA? Pancreatitis is a known complication. We have burnt a finger once, but after that we became very cautious, and anything which is close to the pancreatic duct by 5 millimeters. So even if you're trying to stay within the lesion, the duct is very close, we put a ERCP and a pancreatic duct stent 1 or 2 days before. The reason 1 or 2 days before is that if it's ERCP which is causing a pancreatitis, we'll at least know and avoid the next intervention. And some people also use indomethacin suppository, the French group. GI bleed is quite common, especially if you go through a vessel, because now you're burning the vessel wall, not just puncturing it. And third is the perforation. All have been described in literature. And so avoiding the blood vessels is important, except the tumor vessels which are within the lesion. So this is another lesion which is very close to the pancreatic duct, had a stent, and then we did RFA. So this was 2 days before. Sometimes the duct is so close and you are still scared and you do only a partial work. So completeness of RFA may be suboptimal if the lesion is very, very close to the PD. And this is a patient who had a significant vascularity in the lesion, and you can see the bleed happening. Also has a stent, you can see deep down. And this is the bleeding which we see at the end of the procedure. This was a patient of RCC actually, which had renal cell cancer, which was operated, but had many years later had developed a metastasis to the pancreas, and we had burned that. RCC is quite vascular lesion, but we kept observing and washing, and in the end, about 3-4 minutes later, we could see there was no further bleeding. So that made us a little more relaxed, and then we could complete the procedure. There also can be device injury, especially if you're in a very awkward position in the second, third part of duodenum. In long position, the sheath or the insulated sheath can get ripped off, and that can extend your depth of burn. So mind you, if your device is not moving in and out easily, you should be aware of this adverse event, and this can cause more longer depth of burn, and which can cause complications. So you are initially aware of only 1 centimeter, but suddenly it becomes 2 centimeter depth of burn, which can cause perforations or GI wall injury. So in the end, I would like to conclude by saying that the EUS RFA is safe. It's quite effective for functional neuroendocrine tumors, especially insulinomas, where we have got reasonable amount of experience. We've extended it further to non-functional neuroendocrine tumors, and we have been ablating them, provided that lesion is away from the PD. But if they're close to it, then we always use a pancreatic stent along with rectal endomethacine nowadays. They can be considered for pancreatic ductal adenocarcinomas if nothing else is working out for them. But the caution which must be kept in mind while doing US RFA is to avoid interposing pancreatic duct, avoid blood vessels, and whenever you're coming very close to the GI wall, stop the burn. Thank you very much for your kind attention.
Thank you, Dr. Sandeep, for that excellent talk. One question I have, how long follow-up do we have in these patients? And what are we benefited with after this therapy?
So, Praveer, that's a very valid question, and many people have asked that. And so we started first somewhere in 2015 with using insulinoma only as our first cases who are not fit for surgery, which we reported a long time back in GI endoscopy, a series of 3 patients only, but they had tremendous response. They were very, very symptomatic and they were unfit for surgery, which is the standard of care. And that's why, and that gave us a lot of encouragement that we can carry it further. So currently we have about 10 odd patients with a reasonable amount of follow-up now, varying from 6 months to 6 years, and they have been doing well. The tumor does not come back and they remain symptom-free. That is, no hypoglycemia, and which was the main symptom for which they came. Having said that, we expanded our indication to non-functional neuroendocrine tumors, which again by the NCCN guidelines require surgery. But they are totally asymptomatic. Doing a radical surgery in these patients is debatable. The current standard of accepted complications for neuroendocrine tumor is 50% at surgery. So they have 50% complication rate at surgery, which is accepted, which is quite high by any standards, I would say. So that's why we thought, why not try something else? And so non-functional tumor, the only drawback is we don't have how to follow them up, because we are burning something. In insulinoma, you have symptoms and insulin and sugar value to follow up. Whereas here we only have a tumor which is a physical lesion non-functioning. So we follow them with their size, the baseline size by CT or MR, and also by ECG, and then that's the way we follow it up. If they don't grow inside and regress, which we have seen, regression is quite common and finite, sustained, it makes sense to do it. Neuroendocrine, apart from neuroendocrine tumor, the adenocarcinoma is a different ballgame altogether, where nothing really works. Even surgery fails, and they instead of opening and closing those patients, and if they're big tumors and they have pain, which is the dominant symptom, and alcohol ablation is not working for celiac plexus, then this may be one of the methods of reducing pain, and it's also may improve the longevity, but that needs much more longer follow-up and a multi-center kind of experience to come forward.
Dr. Sandeep, I have a question for you. Hi. Two questions. Number one, is there any feature in the lesion which suggests that this is not a good case for RFA? For example, size. Are there any features where you will not do RFA? I mean, indications are very clear. Patient not fit for surgery. I mean, there are and the lesion is unresectable. But are there any features on US which suggest that RFA may not be a good modality?
So the tumor which are currently we are doing is 2 centimeter as a cutoff. Anything which is less than 2 centimeter is what we are preferring. Anything which is more than 2 centimeters, we suggest surgeries. Tumors which also have lymph nodes in the periphery, they will obviously not benefit by this method. So they will go for surgery. But those which have vessels, we are not worried inside the tumor. And those which are close to the PD, we were very hesitant in the beginning, having caused one complication about 4 or 5 years back of pancreatitis leading to pseudocysts, which required drainage. Then we started doing more of PD stenting, and now with a combination of PD stenting and rectal endomethacine, we are now more aggressive with it. So size is the main criteria, and those plus those which have lymph nodes around them.
And what is the imaging protocol? Once you do a procedure, what is the imaging protocol? How frequently you do the imaging after the session?
Yes, so we follow them every 3 months for first year, then every 6 months for second year, and then every year thereafter. This is a protocol that we follow for insulinoma patient, where we check the sugars in the beginning. But in non-functional neuroendocrine tumors, sugars have no meaning. So imaging is the main thing. And we do imaging at once a year then.
Thank you.
So can we invite the next speaker? So to keep up us on the right time.
Yeah, so the next talk is by Dr. Mohan Ramchandani, who will be talking about celiac block and neurolysis by US, a video lecture. Dr. Mohan, please.
Dr. Mohan, you are not audible.
Okay. Can you hear me now?
Yeah, we can hear you now.
Okay, so at the outset, I thank Rajesh for this kind invitation, and thank you, Praveer. My job is to talk you about how to do a celiac block and what are the various techniques which we do with, and what are the comparative results. So celiac block or celiac plexus is first of all, we should know where it is. It is just anterior to the aorta, below the diaphragm. It is a dense network of interconnecting fibers and ganglia. It surrounds the origin of celiac artery. That's why we always trace the celiac plexus with celiac artery. It is located anterior and lateral to the aorta and just in front of L1 vertebra, although there can be variation from T12 to L2, but majority is located anterior to L1, below the diaphragm, anterior to diaphragm and aorta. So this is the landmark. The right ganglia is slightly above than the left, and we should all know that it relays the afferent from not only pancreas, but also from abdominal viscera, almost all abdominal viscera, except left colon, rectum, and pelvic organs. And this is the celiac ganglion, which takes the afferents from pancreas and other abdominal organs and relays to splenic nerve, and through that it goes to the dorsal horn and to the brain. So this is the circuit. So if we break the circuit at celiac plexus, there can be some improvement in pain. So that is what we target. So the celiac plexus can either be blocked by injections of anti-inflammatory agents like long-acting anesthetic agent or steroid, which stunts the celiac plexus, but the things will return back to normal and patient will have recurrences. So better for benign diseases. While celiac neurolysis is completely ablate with chemical agents, it knocks off the ganglia, and chemical agents used are either alcohol or phenol, and this type of therapy will be required in malignant or terminally ill patients. So most commonly, the celiac block is used in pancreatic type of pain. And as we know, the pancreatic pain is a multifactorial, the approach will be multifactorial. You need to see not only the ductal obstruction where the ERCP and ESWL is the mainstay of treatment, but majority of the patient have a wiring problem rather than plumbing problem. And these patients who have either normal duct anatomy have pain, or those who have long-term pain because of the malignancy, they have pancreatic neuropathy, and there is an increased intrapancreatic sensory nerve and inflammation to the nerve sheath causing this pain. And this pain can be tackled by the CPN or CPB. So as I told, the malignant disease like pancreatic cancers will be treated by neurolysis, while the patient who have chronic pancreatitis should be offered blocks. Those patients who have other abdominal malignancy, I think Praveer is here and he has published a very good paper on gallbladder malignancy. They also found very good response to celiac plexus neurolysis apart from pancreatic malignancy. We also have a patient who have smoldering acute pancreatitis, recurrent pancreatitis. They need to be treated by CPB. So what are the issues in US guided pancreatic celiac plexus neurolysis or block? what should we use, alcohol or phenol, whether the approach should be anterior or posterior. The EUS technique, we should know whether the central technique or bilateral injections to be done, or broad plexus injection need to be done, which I'll explain in short while, and which needle. So these are some of the issues which needs to be understood in process of celiac plexus block or neurolysis. So first of all, let us talk about what is posterior approach. Posterior approach is basically a percutaneous approach, either fluoroscopic guided or a CT guided, where the injection is done from the back, while anterior approach is usually EUS guided, and it is done through transgastric route, and the injection is done anteriorly. So this is how the fluoroscopic approach is done, and this is how the EUS guided celiac plexus neurolysis block is done. Now, which technique is better, whether it is percutaneous or EUS? We did a randomized control trial long time back in 2009 and included 27 patients in each group with EUS guided celiac plexus block versus percutaneous fluoroscopic guided celiac plexus block, and found out that the pain score improvement was much better with EUS guided celiac plexus block as compared to percutaneous block. So now we know that EUS guided is more scientific approach where we see and block, while percutaneous is mostly image guided, and usually a lot of guesswork is happening over there. So EUS is much better than percutaneous. The second question is what technique, whether we should inject centrally or unilaterally or bilaterally, whether the ganglion neurolysis to be done, or what is this broad plexus neurolysis. So let us come to one by one. So this is the technique which is the central technique, unilateral, only one side, central is to be done. Every patient pre-procedural hydration should be done. As soon as patient should come, we should at least give 1 liter of saline to prevent post-procedural hypotension. Left lateral position is the most important. Patient should be given anesthesia with either propofol or deep intravenous sedation. Antibiotic prophylaxis is operator dependent because you mostly use alcohol, which itself is a bactericidal, but still we have seen the incidences of retropancreatic or retroperitoneal abscesses because there can be a bacterial translocation from the gut. And this can be minimized if you do a single bath or you avoid gastric acid suppression. The needle used here is 22 gauge needle, or preferably the dedicated needle which comes for the celiac block. 20 gauge needle should be used, which has got spray holes. So the technique is you have to first localize the takeoff of celiac artery and superior mesenteric artery, and just at the angle you have to first of all pierce that area, and there will be a dead space in the needle, and once you are piercing you will have some tissue inside, so inject 3 ml of saline to get rid of that tissue. The second thing which you should do is aspirate. Always aspirate to see whether the needle has gone into any arterial structure or not. Once that is done, then you are in the safe zone. That means you have gone into this area where the celiac takeoff is being done and your needle is right there. You now have aspirated and now you are in the right place. So depending on whether you are doing a celiac plexus block or neurolysis, you can inject the local anesthetic agent like bupivacaine or lidocaine, and then followed by, so this is the first step where you locate that area. Now the second thing which comes is whether you want to do at one place or you want to do bilateral. If you want to do bilateral, you have to locate again the celiac artery over there. Then you have to rotate the scope clockwise till the celiac artery disappears. And then you have to inject in that area. So that is the left side. Once you do left-sided injection, similar way, as I told, inject 3 ml saline, then aspirate, and then inject either of these depending on what you have decided, whether you are doing neurolysis or you are doing block. Once this is done, then you have to again rotate back till you see the celiac artery again, and then keep on rotating to the right, and then you inject in that situation. So you have to inject bilaterally. Now it is important for us to understand that if you inject around the celiac artery, it is not enough. Sometimes you have to go caudally till the superior mesenteric artery. That has been explained by Anand Sahai, and that was the main reason why the bilateral was better than unilateral. When they injected not only at the celiac artery origin, but also went caudally till superior mesenteric artery. And that is why they have shown that the bilateral is better than unilateral. So we'll come back to that. But if you decide that the third thing, that you want to inject celiac ganglion, so you need to understand that how you will differentiate between a lymph node and celiac ganglion. The celiac ganglion are located lateral to the celiac artery. They are having similar echogenicity as that of left adrenal gland. The margins are irregular. You can see the irregular margins. There is central echo-rich foci. If the ganglion is long, you can see this central echo-rich foci. Then there will be some thread-like structures coming out. If you are lucky, you will get it, but you may not get it in all. So to do celiac ganglion neurolysis, you need to first of all locate it between the adrenal gland and celiac artery. And these are the irregular border-shaped celiac ganglions. And the method is you have to pierce these ganglion right at the distal. You have to go to the caudalmost or far away margin, and then keep on injecting and come out. You can see here this video where the needle is right at the distal margin of the ganglion, and then you start injecting alcohol, and you can see already, you can see this clouding of the white clouding of that area, and you can already see the spillage. So celiac ganglion is never limited to celiac ganglion. It spills around that also. So we have to take those studies with a pinch of salt, whether celiac ganglion alone is important or it is the surrounding structure which also get ablated along with the celiac ganglion. So this is how you should not restrict to one. You may find 2 or 3 celiac ganglion, and you have to do one by one, similar way. Go to the distal margin, keep on injecting and come out, and you can see the spill around it. So that is how you do direct celiac ganglion injections. So coming back to now, we know that there can be a central injection, there can be bilateral injection, and then there can be a celiac ganglion injection. So what will you do? So if you see this meta-analysis, which is widely quoted, whether central is better or two-sided is better, the bilateral injection has shown to be superior to unilateral injection. The second study, which is 160 patient study, again by Anand Sahai, they showed that bilateral CPB or neurolysis was much more effective than unilateral or central. The mean pain reduction was much better with 70 as compared to the central, 70% versus 46%. And it was the bilateral technique only which was responsible for positive clinical response. But as we know, randomized controlled trials are best to say whether to give us the final verdict. And this randomized controlled trial, including very less number of patients, has shown no difference. So what is the final verdict? Whether you do a bilateral or central. So the practice guidelines published in 2017 has clearly shown that if you do bilateral EUS neurolysis with the needle advancement caudally beyond the level of celiac, then bilateral is superior. But technical feasibility is not always there. Operator may not be experienced. In such situation, central injection is an acceptable option. So bilateral, if done technically well, is always superior to central. But if you are not well versed with technique and you just want to inject only on the bilateral of celiac, then unilateral is as good. Now, what is this broad plexus block? Now, if you see this plexus around the celiac, superior mesenteric artery and inferior mesenteric artery, this is a broader plexus, and they are basically divided into 6 zones, right and left around celiac, right and left between celiac and superior mesenteric, and right and left between superior mesenteric and inferior mesenteric. So broad plexus neurolysis improves intensity of pain relief in advanced cancer. This has been shown. And this is a very nice study where broad plexus neurolysis was done, and the 6-zone neurolysis or maximum 5-zone neurolysis was achieved in one group in a better way as compared to the other group where this type of broad plexus neurolysis was not done. The broad plexus neurolysis where 5 or 6 zones, as I told, these all 6 zones were ablated. There, the pain relief was much better as compared to the 1, 2, 3, 4 zones. So broad plexus is much better, but this is a small study, only single study. The low success of bilateral CPN was there, which was unacceptable. They used 25 gauge needle, and there can be more side effect depending on the depth of ablation. So still the broad plexus block is not widely accepted, and we are still waiting for better studies. Now the question of whether you should do a celiac ganglion neurolysis or not. This is a very controversial study published in Clinical Journal of Gastroenterology Hepatology in 2019, which showed that if you do a CGN, that is ganglion neurolysis, or do a plexus neurolysis, the pain response is equal. But if you do ganglion neurolysis, you increase the mortality. The survival was much better with plexus neurolysis as compared to ganglion neurolysis. Now, why it happens? Usually, if you do a plexus neurolysis, there is increase in survival, while if you do ganglion neurolysis, the postulation was that there is a lot of inflammation, and then this may do some tumor effect in tumor modulation, and then there can be increase in the tumor progression leading to early death when you do ganglion neurolysis. So the verdict about whether the ganglion neurolysis be targeted during EUS procedure, the answer is there is no clear evidence that ganglion neurolysis is more superior to bilateral or broad plexus CPN, especially with needle advancement caudal to the base of celiac axis. Therefore, EUS guided CGN is not necessary. So you need not to do ganglion neurolysis, especially when we saw some studies, especially a randomized control trial showing high mortality, and also the effect is not same, because as I already told you, once you're doing CGN, it also spills surround. It is not solely CGN. So it is actually the bilateral or broad plexus neurolysis, because you are doing multiple CGNs, the alcohol is spilling all over, and it is equal to broad plexus neurolysis, not per se. So you should not waste time in finding the ganglion and ablating them. What else we can do in celiac ganglion neurolysis? You can place, you can do a brachytherapy, like place a small, like what we do for fiducial, there can be some iodine needles, seeds, which can be placed in this angle where between the celiac artery and aorta, and there can be a slow ablation of ganglion or plexus, leading to long-term pain relief. There cannot be an immediate pain relief, but patient will have long-term pain relief. So this is one innovative method still under evaluation. What else can be done is radio frequency ablation. What is the problem with alcohol? Alcohol keeps on spilling, and then it may cause collateral damage. So why not to choose a modality which is pinpoint, like a radio frequency ablation? As Sandeep showed, the catheter that which can be loaded on a 19 gauge needle, and you can see this is the left adrenal, and you rotate, you find this celiac ganglion, you puncture this needle by the 19 gauge needle loaded with RF catheter. One French needle, you can see this is a paper from Shyam Varadarajulu group, where they are removing the stylet and then loading this 19 gauge needle with Habib catheter, one French catheter, which is like a needle, and it is like a stylet, and it goes through the 19 gauge needle. And once you have loaded it, you just withdraw the needle inside the 19 gauge needle and then puncture that celiac ganglion like we do in alcohol injection. Once you puncture that, then you have to push that needle. You may not be able to push, but you have to do like what we do in ERCP exchanges. We keep the RF catheter there and withdraw the needle. Once you withdraw the needle, the probe which is there will come out of the needle, and then you can ablate. Now what is happening here is the celiac ganglion is getting ablated. If you do not find celiac ganglion, can we do this? Yes, we still can do that, like blind injection. You can place the needle right at the angle without spotting the ganglion, and then you can pass the 10-watt RFA current, and then you can ablate.
Can you put the summary slide, please?
Yeah. So I coming to that only. So in the end, I think celiac pectin block or neurolysis is superior to percutaneous radiological guidance. Central or bilateral is debatable, but bilateral, if done in properly, is better than central. Direct celiac ganglion neurolysis is not recommended. We need well-designed randomized control trial in this subject to have more knowledge about these factors, including the brachytherapy, the radiofrequency ablation of celiac neurolysis. Thank you very much, Praveer.
Thank you, Dr. Mohan. I think we have exhausted the time. We do have 3 questions put up. So Dr. Puri, can we take up those questions, or we should begin panel discussion?
Already late. So
Okay.
you can ask one question, please. You can ask one question, please.
Yeah. So Dr. Mohan, one of the questions that has been put forward is that by Dr. Nikhil, in bilateral technique, how deep should the needle be inserted? I saw in your slide you mentioned it should be beyond the celiac. How long? How much beyond that?
So, Praveer, all the studies which has shown the randomized control trial, which showed that bilateral is not superior to central, versus those studies which have shown bilateral is superior to central, there is only one technological difference. What is the difference is if you go towards not only celiac artery, but also insert the needle up till to the superior mesenteric artery and ablate both the things, then only the bilateral is better than central. Otherwise, central is equal to bilateral.
Thank you, Dr. Mohan. I think we need to end this session. I would like to thank all the speakers, Dr. Moon, Dr. Randhir Sood, Dr. Pramod Garg, Dr. Kida, Dr. Laktake, and Dr. Mohan for an excellent delivery of the lectures. and the chairpersons for the same.